Hi, everyone. My name is Lily. I'm the Billing and Office Manager at Community Health Resource Center. Thank you all for joining us for our annual Breast Health and Breast Cancer Care panel presentation. I feel very fortunate that CHRC gets to be a part of such an important presentation every year. Quickly, I just wanted to share a little bit about our organization for those that haven't joined our programs in the past. Community Health Resource Center is a nonprofit organization here in San Francisco. We were established nearly 40 years ago by doctors at California Pacific Medical Center to provide resources and care that would supplement their work with patients to support their overall health and well-being. Today, we provide 4 main areas of service. Those are behavioral health, nutrition counseling, community health screenings, and health education. And with that, I'll pass it along to Dr. Ann Peled, our moderator for today's presentation.
Great. Thank you so much, Lily. And I wanted to say another huge welcome to everyone for joining us. And thank you to Lily and her team. We were just talking about, we've done this for several years at this point in partnership with the CHRC. And we love this as a way of getting together a lot of different specialties and really highlighting some of the things that we do at CPMC, but also really helping people in terms of thinking about innovations and advances and how to better take care of their breasts. So just to kind of talk about our program here at CPMC, I feel very fortunate to be a part of this program. It has a huge breast imaging center, actually the largest one in Northern California. And one of the things I think that makes our program very unique is the multidisciplinary nature of it. And again, you'll see that highlighted through our speakers tonight. Certainly, we have a very extensive support services and resources for our patients going through treatment and really focus on community outreach and education like this. This is the Center for Women's Healthcare. For those of you who haven't been, it's beautiful. I got my own breast imaging here, and really they do a beautiful job making sure that patients feel taken care of and safe at what can be a really incredibly scary time. In terms of some of the things you'll hear about some of these tonight, but I think in general, one of the things I love about doing this every year, especially in Breast Cancer Awareness Month, is really not just thinking about raising awareness, but really letting people know what are the advances and what are the innovations that we see. So I think one of the ways we do a great job, again, which you'll hear about tonight from Dr. Holtz, is thinking about how are we improving our ability to screen and diagnose breast cancer so we can have a better understanding of risk. We have a better understanding both of imaging in terms of breast density and risks around that, but also, as you'll hear from Deezy, from our genetic counseling team, about genetic testing and who should get it and why. And then also we have this ability to have these tailored screening plans that really help you know your risk and get your best plan for you. Additionally, we continue to know more and more about tumor biology. We have ways to test tumors and think about chance of recurrence. We have what's called genomic testing that really allows people to make a tailored decision for them that allows them to weigh the risks and benefits of treatment, but actually know what the real benefits are for them specifically. I think the other thing that's especially fun, I'm a breast cancer surgeon and also a breast plastic surgeon, is sort of seeing how much more focus there is now on survivorship. So we always say wonderfully, we can treat breast cancer incredibly well nowadays from an oncologic standpoint, but we also get to think about what are the negative side effects of what we're doing? Are there ways we can do less invasive surgery? Can we think about minimizing the side effects of treatment, such as targeted radiation therapy or oncoplastic surgery that helps people look potentially better than they started from breast cancer surgery? So again, there's a lot we can do that really advances the care in this way that is very patient-centered. The other thing that I always like to bring up is today is actually, we always do this on the third Wednesday of the month, and it is a national day for breast reconstruction awareness. And I think for a lot of people may not realize that breast reconstruction is in fact covered by insurance. It's mandated to be covered by insurance for anyone going through any kind of breast cancer surgery. I always say anything that happens to your breast after your diagnosis has to be covered legally, whether it's lumpectomy reconstruction, mastectomy reconstruction. And unfortunately, there's still a lot of disparities that exist. And so having conversations like this, talking about innovations and advances, really allows us to level the playing field for everyone going through this. So really excited about our speakers today. We're going to start out with Daisy Tapia, who's one of our genetic counselors, and she's going to take us through kind of cancer-specific information about testing, in particular as it relates to breast cancer. Elena Zidaru is a new addition to our group focusing on nutrition, and I have to say I'm incredibly excited about this. It's a topic I love learning about, and I think all of us could really benefit from learning more about prevention and treatment as it relates to nutrition. Dr. Jamie Holtz is one of our breast specialized radiologists, and she's going to be talking through screening and treatment and advances and density and all sorts of great things that we all need to know in terms of screening. And then finally, Dr. Kjirsten Carlson is going to be talking about kind of what I like to think of as her favorite new and exciting things in the world of breast surgery and breast cancer care, which we're all going to learn a lot from. So we all love to answer questions. As Lily mentioned, please put them in the Q&A section. I'll answer some of them that are easy and straightforward. I would like to remind everyone, though, that unfortunately we really can't directly comment on your medical care in this setting, but we can certainly, answer questions in general about what it's like for people to go through that. So with that, I'd like to pass it on to Daisy, and we're really glad you're all here.
Hello, everyone. A pleasure to be here. My name is Daisy Tapia. I'm a genetic counselor at CPMC Sutter, along with my colleague, Elizabeth Cart, or Sinat, sorry, and talk to you today about genetic testing. So a little bit of what I want to discuss with you today. Of course, start off with an overview about hereditary cancer with an emphasis on breast cancer, who should consider genetic testing, what are some of the benefits of testing, as well as going over specific genes related to breast cancer, what to expect in terms of results for genetic testing if you're going through this process, and what are the implications for family members as well. And we'll touch on some of the advances in genetic testing as well as some additional considerations. So this is something that I like to go over with all of my patients. It's a pie chart that kind of shows the distribution of cancer cause. And really anyone can develop cancer at some point in time. That's why we recommend general cancer screening for breast cancer and other cancer types as well. Most cancers are considered sporadic, which really means it can kind of happen by chance. Only a small subset of cancers, about 5 to 10%, are considered hereditary, meaning we are able to find a single genetic mutation that can explain a predisposition for developing cancer. In addition to that, there are sometimes what we call familial cancers, which basically encapsulates families where we are seeing a strong family history of cancer, but current testing technologies are not able to identify anything. And so, what genetic testing is looking for is who are those individuals who do fit into having, hereditary mutation. So what actually is a mutation? A mutation is really an alteration in how our gene is written, kind of akin to a spelling mistake. And genes are made up of DNA and our basic instructions for our bodies. And most of the genes that we're talking about in terms that we're testing for related to cancer risk are actually there to protect our body against developing cancer. So when they're mutated in a way that that instruction is no longer able to make its functioning protein product, we basically see that people have a lower threshold for developing cancer. And who are some of those individuals who should consider getting genetic testing? So our guidelines are constantly evolving over time and luckily evolving to cover more and more people. But currently, we still recommend testing based on specific types of cancers. For some, it doesn't matter what age someone's diagnosed. So for ovarian and pancreatic cancer, as well as metastatic prostate cancer, or even male breast cancer, we're recommending for everyone who has that diagnosis to get genetic testing regardless of age. For other cancer types, it depends on that age. So of course, for breast cancer, currently we recommend for all women diagnosed with breast cancer under the age of 50 to definitely do genetic testing. But our guidelines are expanding on that. And now we are making it available to all women diagnosed with breast cancer regardless of age. Also, when you look at your family tree, if you're seeing that there are multiple relatives on the same side of the family that have similar or same cancer types, then that can also be an indication to consider testing, especially when thinking about relatives that are more closely related to you, such as first-degree relatives like parents and siblings, and then expanding that to second-degree relatives like aunts and uncles, grandparents as well. We also look for rare patterns that can be more indicative of cancer syndromes, such as triple-negative breast cancer. And we also know that, certain individuals or individuals of Ashkenazi Jewish ancestry can have a higher incidence of particular mutations. So that's something that would also prompt testing as well. And ultimately, if it's genetic testing is something that you're interested in, even if you don't have a personal history, it can be really useful to meet with a genetic counselor to go through the evaluation process and look at that family history to see what's there. So what are some of the benefits of genetic testing? Ultimately, the whole goal behind genetic testing is to learn what individuals are at increased risk for cancer so that we can change screening, typically recommend enhanced screening, either starting earlier or doing it more frequently than what's recommended for the average risk individual. If someone has a cancer diagnosis, then that can lead to differences in treatment, maybe considering a different type of surgery, maybe considering more personalized treatments in terms of targeted medications. And then, of course, it can have rippling effects of being able to inform who else in the family is at high risk. So this page has a lot of information here, but essentially each column on this graph is a different gene that we test for that's related to breast cancer. And we're comparing it to what's the lifetime risk a woman has to develop breast cancer if they have a mutation in that particular gene. So keep in mind that all women, we all start at our baseline risk, which is about 12 to 13%. And if we can focus on 1 and 2 genes here, most people, if they are aware of genes related to breast cancer, are familiar with BRCA1 and BRCA2, which are collectively referred to as BRCA genes. They're on the left side here, and we can see that women with those, a mutation in either one of those genes has greater than 60% lifetime risk for developing breast cancer. So we definitely want to be able to identify what individuals have these mutations so we can make implementations for different screening. To show here is that all of these genes are a little bit different. So we focused on BRCA1 and 2, but on the other end of the graph, we see that those genes have lower risk. So therefore, the recommendations about what is the frequency of screening, how early are we recommending to start screening really differs depending on which gene ends up being affected. To focus back in on BRCA1 and 2, most of these genes that we test for have implications beyond just one cancer type. So BRCA1 and 2 are also related to ovarian cancer, to prostate cancer for men, pancreatic cancer for both men and women, male breast cancer, and skin cancer for one of them, BRCA2. So again, can have recommendations for other forms of screening as well. Now, when you get your test result, hopefully a genetic counselor is walking you through it, but ultimately for each gene that we test, there are 3 different outcomes. We can get a negative result with everything looks normal. A positive would mean that we did find a mutation. In that case, the genetic counselor or clinician who helped coordinate the testing for you will hopefully walk you through the implications about what gene ends up being affected, what are the cancer types related to that specific gene, and what are we recommending for you specifically in terms of surveillance and management for the future, and what does that mean for family. A VUS, it's something that sits right in the middle. And if any of you have had genetic testing, you might have encountered one of these. But essentially what that means is that, yes, there was a mutation found in your genetic testing results, but it's not actually clear if this mutation is actually disrupting gene function and represents something harmful, like a positive, or is it actually just normal human variation? And we do know historically that most uncertain results are eventually found to be normal human variation or not harmful. And that's why it's really important to know to expect that we might encounter 1 or 2 uncertain results, but ultimately we're going to treat them clinically as negative because most of the time they're normal human variation. What are these results mean for your family? You know, if someone does end up testing positive, then we know that that individual inherited that mutation from either their mother or their father. I think sometimes there's the misconception that, we only need to focus on the maternal side of the family, but that's not true. We can inherit mutations from either parent. We get half of our genetic information from each parent. So it is important to look at the paternal side of the family as well. And that does mean that when an individual is found to have a mutation, each full biological sibling, as well as each child, has an independent 50% chance to also have that same genetic mutation. So typically when someone is identified to have a known harmful mutation, a positive result, we do recommend genetic testing for all first-degree relatives so they can help clarify their risk, adults, individuals. And what are some advances in testing? So mostly now, most clinicians are ordering multi-gene panel testing, meaning we're not just looking for a single gene. As we saw earlier, when we're looking at breast cancer, there are 13 different genes. So we want to make sure we're looking at all of them, because technically someone can have a mutation in any one of those genes. And so we want to not miss anything. Beyond that, though, we're now typically doing comprehensive testing that extends beyond just looking at genes related to one cancer types. But of course, there's nuances within the size, and so genetic counselor will discuss those options. But also, we're now doing what we call paired testing, where we do a DNA analysis and also an RNA analysis, which helps us get a bit more information beyond what we were able to do with just DNA only. And it does provide a sliver more information. And so that's our current most up-to-date testing that we are typically ordering for most patients. And one thing to know about that is that can only be done with blood. So what are some additional considerations about genetic testing? So of course, how can someone get testing? Typically that involves meeting with a cancer genetic counselor, such as myself or my colleague. And that really extends beyond CPMC. Most large medical institutions have their own team of cancer genetic counselors who can really go through and look at that family history, help walk you through what to expect, make a choice about what size test feels right for you, and then walk you through those results. But there are other medical providers who can order this testing as well, and so that's something to be aware of. Sample types we alluded to earlier. Historically, we can do testing with blood or saliva, but with RNA, that newer technology, that can only be done with blood, and it does have to be a specific test kit that is ordered, because it's a little bit different than our standard EDTA blood tube. The turnaround time for testing does take a lot longer than a standard blood draw, so we're expecting results around 2 to 3 weeks. For folks who are newly diagnosed, we do try to get those in sooner than that. So typically for someone who's newly diagnosed with breast cancer, we're ordering expedited testing, which typically comes in at about 5 to 10 days. And so that is useful to keep in mind. In terms of insurance coverage, so generally speaking, most insurances do provide coverage of testing if someone meets our clinical guidelines, but there's a lot of nuances in terms of whether or not a patient has an expected out-of-pocket, depending on their specific plan and things like that. So we do work very closely with the billing department at the laboratories to help people get clear answers, because I know that billing is something that we all want to know ahead of time prior to jumping into testing. And also something that we really emphasize and make sure to discuss with patients is genetic discrimination. So prior to 2008, we didn't have this law called GINA, that's called the Genetic Information Non-Discrimination Act, which really helps protect patients. So health insurance companies and employers are not allowed to use genetic testing information to discriminate against patients. So that is something we make patients aware of, but also the limitations of that is that it does not extend to specialty policies like life, disability, and long-term care insurance. Okay, well, I hope that was helpful for everyone, and if there's any questions, I'll be here at the end and help answer them.
Perfect, Daisy. That was so great and so comprehensive. Thank you so much. So now I think we're going to move on to Elena from a nutrition standpoint. Thank you.
Hello, everyone. My name is Elena Zidaru. I'm one of the dietitians with the Community Health Resource Center, and I work with patients with breast cancer through the Breast Health Center at CPMC. And I have here my agenda for today. So I want to discuss a little bit the Community Health Resource Center and Breast Health Center relationship. What a nutrition counseling appointment with an RD kind of means. And I have a couple of nutrition and breast cancer myths that I would like to discuss, common questions I get from the patients that I talk to. And then I will do some brief basic nutrition information, recommendations for reducing risk of breast cancer. I know we all kind of want more time for questions that pretty sure you're going to have towards the end. So I'll try to be brief. CJRC has a contract agreement with CPMC Breast Health Center. So we started this relationship in January 2019, and I was fortunate enough to be one of the dietitians starting working with Breast Health Center. And I have to say, I love working with the breast cancer population. Women are very motivated, engaged, curious. They just love the information and just being usually proactive and trying to make changes to reduce the risk of breast cancer. So this nutrition service is offered free of charge to breast health center patients through the Knocking Family Program. As I said, we have this relationship for almost 6 years, and there's the dietitian, so the nutrition service and the behavior health service, the social worker services provided. The way it happens is that we receive nutrition referrals mainly through the EPIC system from breast health center nurse navigators, mainly. But in reality, any cancer healthcare provider member can refer patients to nutrition counseling. So that includes social workers, health psychologists, medical oncologists, breast surgeons. So anybody that will identify a patient that's interested in learning more about nutrition or has nutrition needs during treatment can refer patients to us. Again, via EPIC system or just via email. Lily, that she's helping us today, she's wonderful. She's our office manager, and she usually contacts the patients within 5 business days from the time of the referral to schedule an appointment with a dietitian. So the appointment is kind of scheduled ahead of time. It's about 50-minute appointments. It's almost a full hour and includes follow-ups as needed. It can be via Zoom, phone, or in person based on what the patient prefers. And the appointment is geared towards patient's needs. So oftentimes I meet with the patient actually before treatment. I might discuss, especially if they need to go through chemotherapy, nutrition tips during chemotherapy to prepare them, just to maintain their nutrition status as much as possible. Sometimes after breast surgery, just again, talking about some nutrition tips and how to optimize the healing. And a lot of referrals actually kind of happen after treatment, during the survivorship, after the survivorship care plan was established. And a lot of times women prefer to talk with the dietitian then, because, they're done with the treatment, they're ready to receive more information, to possibly make changes to reduce risk of further reoccurrence. So as I said, the appointment can be different based on the needs and where the patient is in that particular moment. I wanted to talk a little bit about diet now, right? And some basic information about diet and nutrition, diet and breast cancer risk. So about 30 to 35% of cancer deaths in the US are related to diet-related factors, right? So I have this picture here that I love, which kind of shows that sometimes it's not necessarily the foods we choose to eat that can increase the risk of cancer. A lot of times those processed foods, less nutrient dense, are definitely more pro-inflammatory and can increase the risk of cancer development in general. But a lot of times it's actually the other foods, those foods that we're actually not eating, the healthy nutrient dense foods that have phytochemicals and powerful protective chemicals that will reduce risk of breast cancer. So moving forward, I wanted to discuss a bit the basic 2 myths that I hear about all the time. So sugar that causes breast cancer, or sugar feeds cancer cells. And I usually tell women there's no cause and effect relationship between sugar and cancer, including breast cancer. So we can't really say if you eat sugar or a lot of sugar, you're gonna develop cancer. For sure that doesn't mean sugar is good for us, or we could eat it as much as we want. There's definitely consumption of excessive sugar can lead to weight gain and increased inflammation, in our body. So it's been shown with studies that when we consume a lot of sugar on a regular basis, that can increase the pro-inflammatory cytokines in our body and just that systemic inflammation. So it's not a good idea. Of course, we need to use sugar in moderation, but definitely I met some women that are very scared of touching any sugar in any form. And I feel that that usually kind of adds more stress and more anxiety than actually can be helpful. So I say in moderation, using it as something or like a treat, not something that you do on a regular basis, would be the best approach, and focusing more on whole foods and natural sugars that will come from different foods like fruits and carbohydrates. I have some patients that are also very limiting in terms of carbohydrates, regardless of the type of carbohydrates. So any kind of carbohydrate food is perceived as turning into sugar into your blood, and that will feed the cancer, which again is not really true. The reality is that every single cell in our body feeds on glucose, on sugar. That's the fuel for the cells, and cancer cells will do that too. But not eating any carbohydrates in any form, your body will still make blood sugar from blood glucose from protein and fat. So it's not really an effective, good, healthy way of managing your diet long term as a way to prevent cancer from developing. So this is some certain things that I talk with the patients, and then what to do. Well, eat added sugar in moderation. American Heart Association recommends no more than 24 grams of added sugar a day for women and 36 grams of added sugar a day for men. The less the better. You know, I tell patients, you don't have to get to this budget to maximize it every day. Some days you could eat even less than that. And if there are days in which you reach the budget, that's totally fine. That's considered in moderation. One of the best advice I like to give is eat whole foods and limit the processed foods. A lot of added sugar comes with processed foods, foods that we're not necessarily thinking of having sugar, like a box mac and cheese or a salad dressing that otherwise seems and looks healthy. Or maybe, you know, ketchup or a cracker. Slice of whole wheat bread can have up to 5 grams of added sugar. When you really minimize those foods that have added sugar and you start reading nutrition labels, you're going to realize you have, in that budget of 24 grams of added sugar, you have room for a treat when you feel like having one. So this would be one of the ways to kind of manage the sugar intake. The second myth would be around soy foods that can increase risk of breast cancer, especially the estrogen positive ones. And the reality is that soy foods have isoflavones, which are phytoestrogens, and they have a similar chemical structure with human estrogen, but they've been shown with lots of research studies that were done on US population. They're similar in chemical structure with the human estrogen, but they're not identical, and they do not really act like human estrogen. That being said, they could fuel a cancer cell. So it's been established that it is safe to include whole soy foods as part of a healthy plant-based diet, even after a breast cancer diagnosis is estrogen positive. In fact, there are good preliminary studies that show that soy foods may be protective against breast cancer recurrence because of, again, that similarity in chemical formula can allow them to block at the receptor cells and actually block the effect of human estrogen that could fuel a cancer cell. So especially when we talk about plant-based diet being more protective against cancer recurrence, those whole soy foods, tofu, tempeh, edamame can be good, lean type of protein that are plant-based. It can be very helpful. So what to do? You could eat safely 1 to 2 servings of whole soy foods, even as an estrogen-positive breast cancer survivor. And there's some examples of what's a serving: half a cup of tofu and tempeh, half a cup of shelled edamame beans, and 1 cup of soy milk. Those are examples of whole soy food servings. And still to limit processed soy foods. So those were, a lot of them were not included in the study that, you know, we talked about showing safety in consuming the soy foods. And not just that, again, we can't say they're harmful because they're not, but they're processed foods. So I say they have more sodium. They actually have way lower levels of isoflavones, which are the ones that are pretty protective and healthy components of soy foods. So, you know, I don't really look at the processed soy foods, which would be, let's say, a soy burger or a protein bar made out of soy isolate or concentrate. I don't put them in the same category as the whole soy foods in terms of rendering those health benefits. So again, not to say they're bad for you, but I won't use them on a daily basis. You know, more occasional as needed, but not as a kind of daily consumption part of a healthy diet. And then I have some basic nutrition recommendations for reducing risk of breast cancer. I want to kind of say, and I tell all the women I talk to, we really don't have a cause and effect with any food. So we cannot say if you eat this food, you're going to develop breast cancer. For sure, there's no such a cause and effect relationship with any food and breast cancer. And of course, there are dietary patterns that can reduce the risk of reoccurrence. There's certain behaviors and eating habits that could increase the risk, right? But there's no cause and effect. So I always like to focus on the pattern, what people and women do most of the time, what they eat most of the time, 80–90% of the time. If you have 1 or 2 meals in a in a week, that's, you know, maybe not the best. I don't think anybody should worry or become anxious about that. So eating a plant-based on a regular basis, 80–90% of the time, with an abundance of whole grains, vegetables, fruits, legumes, nuts, and seeds. All those plant-based foods have phytochemicals that are having anti-inflammatory properties in our body. It's nice to know that you could fight that inflammation that can happen for other reasons, like maybe you're sedentary, or you're sleeping poorly, or you have a lot of stress in your life, or you're you know, exposed to certain environmental factors that can increase inflammation. So it's nice to have a diet that you eat on a regular basis that could counterbalance that inflammation that happens for different reasons. Limiting alcohol intake can be one of the steps to reduce risk of breast cancer. Maintaining a healthy weight, especially in postmenopausal women, that association is stronger. So trying to maintain a healthy weight and not carry a lot of extra body fat. Being physically active is definitely a protective factor. I like to emphasize that a lot. And it doesn't, you know, I say you could start small and then just gradually, if you're consistent with whatever you are able to commit to, and then you could gradually increase. This would be the best approach. Limiting red meats and processed meats. So those some are part of the nutrition recommendations. I usually, in my appointments with women, I emphasize cruciferous vegetables, and I talk about vitamin D and ground flax seeds and other foods that we know can be possibly protective and answer questions that women may have as part of, maybe they read the information online or heard from family and friends, and they kind of want to check about the validity of that information. The American Institute of Cancer Research has this new American plate. So under a plant-based diet, this is a little bit of confusion that I hear. A lot of people think that a plant-based diet means you have to be strictly vegan, which veganism, it's part of the plant-based diet, but does not reduce to it. So plant-based diets, it's kind of an umbrella term. And what it really means, it means that more than half of the foods on your plate on a regular basis should come from plants, right? So these are some examples. The minimum, it's kind of what American Institute of Cancer Research recommends when they say a third of your plate to be the protein, a third the vegetable, a third the starch. So that would be 66%. So 2/3 of your plate would be plant-based. So that's kind of the minimum. There are variations, you know, sometimes when women need to manage their weight too, I recommend half a plate vegetables. So then it kind of reduces the calorie density of the plate, and then the other half split in quarters, the protein and the starch. This way you have about 75% plant-based. Of course, I also like to challenge women and say once a week, maybe if you're not doing that already, you could have 100% plant-based, and the protein instead of chicken or fish or eggs or other, you could have beans or tofu, tempeh, so like a plant-based type of protein. And here, this is the last slide I have. This is again from AICR recommendations for cancer prevention. There's 10 of them. But this is just cancer prevention in general, not geared towards breast cancer. Keep a healthy weight, be physically active, eat a diet rich in whole grains, vegetables, fruits, and beans. Limit consumption of red and processed meat. Limit consumption of sugar-sweetened drinks. They spike the blood sugar the most. Limit consumption of fast foods and other processed foods high in fat, starches, or sugars. Limit alcohol consumption. Breastfeed your baby if you can. For mothers, do not use supplements for cancer prevention. And after a cancer diagnosis, follow our recommendations if you can. So kind of start all over again. With the supplements, I get a lot of questions about that, but the reality is that the information is all over the place. I usually say if you need to take a supplement for a particular reason, and there's some exceptions like vitamin D that we don't get a lot from our diet or sun exposure. But a lot of times we're taking just supplements because we heard them may be helpful. This is good. The reality is the more you kind of put into your body, the higher chances of interaction with with other supplements or with other medications you're taking. And those can be very hard to predict in terms of how they react in your body and what they can do. So I like to keep my recommendations about supplements to a minimum of, do you really need to take a supplement, right? Versus I heard it's good for me, and the more the better type of approach. So that's what I have for today. I'll definitely look forward to get more questions for you, nutrition questions at the end.
Oh, perfect. Thank you so much, Elena. That was fantastic. I really appreciate all that. And I'm sure we'll have questions. So we will move on now to Dr. Jamie Holtz, who will be talking to us from a radiologist perspective.
Great. Thank you so much for the invitation and for inviting me to speak. And thank you everyone for attending. So my name is Jamie Holtz. I'm one of the radiologists that works at CPMC, and I specifically focus on breast imaging. Today, I'd like to talk about updates in screening for breast cancer, and specifically focusing on 3D mammography, which is also known as tomosynthesis. And I'll also briefly touch on breast MRI as well. So hopefully after my talk today, you'll understand the differences between 2D and 3D mammography. You'll be able to identify the benefits of 3D mammography and recognize the advantages and limitations of breast MRI. So here's just an outline of what I'll be covering. So first of all, I'd like to explain what is a 3D mammogram or tomosynthesis. And it's sort of what it sounds like. It's a mammogram that rather than being two-dimensional, is three-dimensional. So the breast, of course, is a three-dimensional object. And so we are now able to make 3D mammograms where we're able to scroll through the breast tissue and see different slices of breast tissue. And I'll kind of show examples of what these slices or tomosynthesis images look like in comparison to 2D mammograms. I'd also like to talk about who could benefit from 3D mammograms and what is the role of breast MRI in screening. So first of all, why screen for breast cancer? I think we've already kind of touched on this from our other speakers today. But first, I'd like to point out that 2D mammography screening has been routine in the US since the 1980s. And since it was first introduced, they noticed, researchers found that breast cancer mortality rates dropped by 40% or more with routine screening. Mammography detected cancers are also more effectively treated often. They are at a lower stage and tend to have lower rates of recurrence than breast cancers found by symptoms such as lumps. And 3D mammograms, in other words, tomosynthesis, has been patent approved since 1999. However, it did take some time for technology to catch up, and it's been in more routine, widespread use for at least 5 years. Daisy Tapia touched on some of the risk assessments that during her really excellent talk. I did want to talk about some of the screening recommendations from the American College of Radiology. So first of all, they recommend that every woman should undergo risk assessment by the age of 25. And risk assessment takes into account those genetic risk factors, but it also takes into things like family history, factors associated with estrogen exposure, certain prior benign breast diseases that can be detected on breast biopsies. And breast density is also taken into account by several risk factor models, including the Tyrer-Kruzik model, which is the most comprehensive model for calculating lifetime risk for breast cancer. For women at average risk, the ACR recommends annual screening mammography starting at age 40. And women at high risk for breast cancer can begin screening mammograms earlier, starting at age 25 to 30, depending on which of these high risk categories they fall into. So if their calculated lifetime risk is 20% or greater, the ACR recommends starting annual mammograms for screening at age 30. If they have one of those genetic mutations, such as the BRCA mutation, or their first degree untested relatives of someone with a BRCA mutation, the ACR recommends starting at age 30 also, with a note that this could be delayed to age 40 if they're screened annually with breast MRI, starting at age 30. Women with a history of chest radiation therapy before age 30 are also recommended to start screening mammograms earlier, typically at age 25 or 8 years after they completed the radiation therapy, whichever is later. And women with a personal history of breast cancer, atypia, or lobular neoplasia diagnosed before age 40 are recommended to start screening mammograms at the time of diagnosis. Now I'd like to talk a little bit about how tomosynthesis or 3D mammograms can really aid in screening for breast cancer. And what's important to understand for this topic is the concept of anatomical noise. So anatomical noise is referring to the phenomenon where dense breast tissue, which is quite common, in particular in younger women, can obscure things in the breast that can be signs of breast cancer. Things like architectural distortion, which can show up as an area where breast tissue is pulled together, sort of resembling a star, or an area where all the breast tissue gets pulled into a central point, and also low density objects, including masses and asymmetries. High density objects like breast calcifications can be seen on 3D mammograms and tomosynthesis, but they're well detected on 2D mammograms as well. So we do still acquire 2D mammograms. At CPMC, we have technology that allows us to acquire a synthetic 2D mammogram, which allows us to still assess for these high density objects without giving increased radiation dose. So this is a case from the literature from Massachusetts General Hospital of the first breast cancer, which was found by tomosynthesis or 3D mammogram alone. So going through the pictures here on the top left of the screen, the arrow is pointing at an area of architectural distortion. I apologize, this image is a little small and this finding is quite subtle, especially on the 2D mammogram, but it's pointing out this finding here where some of the tissue is sort of being pulled into a central point. And you can see it much more easily on the 3D mammogram image, the tomosynthesis image. This is a slice taken through the breast. Unfortunately, the file is a little too large for me to share where you could scroll through, but this is what the single slice of the 3D mammogram would look like. And it really allows the finding of architectural distortion to pop out. However, the radiologist in this case continued scrolling through the breast and found a second area of architectural distortion that represented another site of breast cancer. And you can see, looking at the 2D mammogram in this area, this was very difficult, if not impossible, to see on the 2D mammogram. So this is their example of a tomosynthesis only finding. This picture down here at the bottom right just shows that those were both taken out surgically and both confirmed to be breast cancers. So as I sort of touched on, tomosynthesis is built around the concept that tissue overlap, especially dense tissue overlap, can mask, and it can also mimic cancers. And this is because, again, the breast is a three-dimensional object. Sometimes when you take those different slices or different areas of the breast and overlap them together, it can mimic something like architectural distortion or a mass. And when you have tomosynthesis available, you're able to scroll through the images. You can see that it's actually just multiple overlapping structures. Tomosynthesis can improve cancer detection rates by allowing you to pick up findings that you might not see on 2D mammograms alone. And it can also reduce the number of patients recalled from screening when you're able to determine that those findings that are mimicking cancers are actually just tissue overlap. Tomosynthesis has shown increased sensitivity for invasive cancers in particular, and one study showed a 15 to 22% increase in sensitivity with tomosynthesis. So this is an example of how the tomosynthesis is acquired. The mammogram machine moves in an arc around the breast for 10 seconds to acquire the image. And it's acquiring images as it's moving around in the arc. And that's how we get the 3D mammogram where we're able to scroll through the breast tissue. So as I've been touching on, tomosynthesis allows for key improvements in detection of masses, focal asymmetries, and in particular architectural distortion, which are important findings that we look for to detect breast cancer with screening mammograms. This architectural distortion can be a very subtle sign. It can be more easily seen on tomosynthesis or 3D mammograms. But tomosynthesis can also aid in margin assessment of masses, which is an important morphological feature that we assess when we're determining the level of suspicion of a mass for breast cancer. Furthermore, tomosynthesis can detect abnormalities not seen on 2D mammograms. So now I have some mammogram images I wanted to show just to illustrate these examples. So here's an example of how a 3D mammogram slice can improve detection of architectural distortion. The circle is around the area of distortion, and it's much easier to see on this 3D mammogram slice as opposed to a 2D mammogram in this patient with dense breast tissue. This is an ultrasound of that area in the patient, and this did correspond to a breast cancer. Again, another example of architectural distortion. This time I'm showing the 2 mammogram pictures. So anyone who's had a mammogram knows that we always take 2 pictures of each breast, and this allows us to determine where in the breast, which quadrant the finding is in. So here's an example of how tomosynthesis can help in the assessment of masses. In this case, the arrows are pointing at a area of dense tissue where you can see there is something being obscured by that dense tissue. This is the 2D image. And then here, this is the 3D mammogram image or tomosynthesis slice that allows us to see the mass more clearly and also to better delineate the margins. You can see that these are what we describe as circumscribed margins of the mass. And sometimes masses can also not be seen on 2D mammograms, but picked up much more easily on 3D mammograms or tomosynthesis slices. So here's where the mass is on the 2D mammogram, and a lot of people would be hard pressed to determine or to delineate it from the rest of the dense breast tissue in this area. But here on the 3D slice, it really pops out much better. This mass is also associated with architectural distortion. So it's another example of how architectural distortion is better seen on the tomosynthesis slice. We also use tomosynthesis in our diagnostic evaluation of findings. So after a patient has a screening mammogram, if we see something suspicious, we will have them come in for additional images. So in this case, this is a patient, this is the 2-dimensional mammogram in the center of the screen. You can sort of pick up on the area of distortion here in the lower breast, but it's, again, much easier seen on the tomosynthesis slice. And this is what we sometimes will do to further assess findings on diagnostic evaluation. This is a spot compression magnification image. And this is a 2D spot compression magnification image. This used to be the main way that we would assess findings on diagnostic evaluation, or certain findings, I should say, on diagnostic evaluation before we had tomosynthesis widely available. We still do use it, but now we have spot tomosynthesis images available also. And this is very helpful in the assessment of masses, asymmetries, and architectural distortion. So this is a different case, different patient. 2D images on the left, 3D mammogram showing, or tomosynthesis slice 3D mammogram image showing the architectural distortion in the center. Again, pops out much better on that tomosynthesis image. And on the spot tomosynthesis or spot compression tomosynthesis image, you can see it even more clearly. So what about radiation dose with tomosynthesis? So first of all, both 2D mammograms and tomosynthesis mammograms use low dose X-rays. Each X-ray projection to acquire a 3D mammogram is lower than a single 2D mammogram. However, you do require multiple X-ray projections to require the 3D mammogram. So putting them together, all those different acquisitions required to acquire the 3D mammogram, it's about equivalent to a single 2D mammogram. And as I mentioned earlier, it is still recommended that you get 2D mammograms or some sort of equivalent to a 2D mammogram because it is important in assessment for certain findings like breast calcifications. And at Pacific Heights Breast Health Center, we are able to use newer technology to acquire a 2D mammogram from the 3D mammogram images. So they are of equivalent doses, the 3D mammograms and a routine 2D mammogram. And just to put it all in perspective, radiation dose from mammograms is about equal to 7 weeks of background radiation that we just get from living our lives here on planet Earth. So radiation dose from mammograms in general is quite low. So who can benefit from 3D mammograms or tomosynthesis? First of all, the American College of Radiology says it's appropriate for screening women of all risk levels. But advantages are especially seen in women who are less than 50 years old and women with dense breast tissue. And that's because of that concept of anatomical noise that I've been touching on. Dense breast tissue does decrease sensitivity of mammography, and 3D mammograms or tomosynthesis can help with that sensitivity. And it is also an independent risk factor for developing breast cancer. So this is why breast tissue density is incorporated into risk calculation models, as I mentioned earlier. Now I'd like to talk a little bit about breast MRI. So breast MRI is the most sensitive imaging test for detecting breast cancer currently available. When combined with mammography, studies have shown that there's a 91 to 98% sensitivity of these two studies together. But specificity can be lower. In other words, there can be a problem with false positives from breast MRI. In patients who are getting regular high-risk screening MRI, this can be somewhat mitigated because prior MRIs can help to improve specificity. When you have those prior comparisons, you can see if findings have been unchanged for years, that does help to reduce the risk of or reduce the rate of false positives. So there are multiple indications for breast MRI. Of course, today I'm focusing on screening. So the most common indication is for high-risk screening of patients at high risk for breast cancer. But we do also use MRI in patients with known breast cancer to determine the extent of their disease. It can also be used to determine response to patients being treated with chemotherapy. And it can be used for certain situations, problem solving, if we see something on imaging, or if patient has a suspicious symptom and we don't see something on other imaging modalities, sometimes we'll do an MRI for that reason as well. So who would qualify for high-risk screening MRI? Well, some of it is the same groups that I already talked about that qualify for screening mammography before age 40. So these first three groups are the same ones that we recommend screening mammograms before age 40. And then looking at these bottom two bullet points, breast MRI is also recommended for women with breast cancer diagnosed before age 50 or with a history of breast cancer, and if the patient has dense breast tissue. It's recommended they start screening with MRI starting at the age of diagnosis. There's some other situations where the American College of Radiology says breast MRI for high-risk screening can be considered. So anyone with a history of breast cancer, regardless of breast density, can consider screening MRI. Women with dense breast tissue without a history of breast cancer can consider screening MRI, or women with a history of atypia or a lobular carcinoma in situ diagnosed on the breast biopsy can consider screening with MRI. And I did just want to point out that this is the screening, breast MRI for screening is in addition to annual mammography. So it's a supplement to annual mammography, not a replacement. Some women choose to alternate their exams so that the exams are done 6 months apart. That way they're getting some form of screening at least once every 6 months. And patients who are known to be high risk can consider referral to a breast cancer so they can discuss the utility of these different screening modalities and follow with them for breast exams, for example. And this bottom bullet point is just listing out some different risk assessment tools available. So now I want to show a few cases of cancer or of breast, high-risk screening breast MRIs. So for those unfamiliar with radiology images where we're looking through slices through the body like this, the convention is as if we're looking from the patient's feet towards their head. So the right side of the screen is actually the patient's left breast. And here there's a small area of enhancement. Enhancement shows up as white on breast MRI. So there's a small enhancing mass in the left breast. And this was a 5 millimeter breast cancer detected on a screening MRI. So very small breast cancer that might not have been seen if the patient didn't have an MRI. Certainly wouldn't, it's very unlikely to have been felt as a lump. This is that same patient and that same area of enhancement just shown in a different projection. So in this image, the patient's head is towards the top of the screen, the patient's feet are towards the bottom. But thankfully, the radiologist didn't stop there. They kept looking, and there was another enhancing mass in this patient. And this was a second 5 millimeter breast cancer in the same breast. And there it is on the other projection. So this is another finding that we look for on breast MRI as suspicious for breast cancer. This is what we would describe as non-mass enhancement. Here again in the left breast. And there are different descriptors that we'll use to describe non-mass enhancement. This is what we would call cobblestone enhancement because it sort of resembles a cobblestone path. This ended up corresponding to ductal carcinoma in situ, which is an early form of breast cancer, or sometimes referred to as precancer. And this is what that looks like in the other projection. All right, so in conclusion, there are advantages to 3D mammograms in patients with not only dense breast tissue, but all patients. I didn't show cases of this, but it can also be very helpful with in patients with less dense breast tissue to see things like low density masses or asymmetries. And even patients who don't have very dense breast tissue overall often will have patches of dense breast tissue. And so it can help detect subtle findings in those patches of breast tissue throughout the breast. So for this reason, it is recommended for all, if it's available, all women to have screening with 3D mammograms. Or it's appropriate for all women to have screening with 3D mammograms. Annual MRI can be an adjunct to screening mammography in patients at high risk for breast cancer. And for patients at average risk of breast cancer, the American College of Radiology recommends screening mammography starting at age 40 once a year. At the Pacific Heights Outpatient Breast Center and also at the breast center at the CPMC Mission Bernal campus, we do 3D mammograms for all patients, for all exams. Thank you, and I hope to answer any questions at the end.
Oh, fantastic, Jamie. Thank you so much. I have so much to talk about with that, but we'll get to that at the end after Dr. Carlson is going to talk to us about a potpourri of advances in breast cancer care.
Wonderful. So as Dr. Peled mentioned, I'm Dr. Carlson. I am a breast surgical oncologist here at with Sutter Health at CPMC. And I'm very excited to talk to you guys today about new technologies and approaches in breast cancer treatment. There's a lot to choose from. I'll try to get through this quickly so we can have some time for questions at the end. I have no disclosures. So I'll talk about a little bit of where we've come from and what the background of breast cancer management was. And then I'm focusing mostly on advances in breast imaging and then as well as surgical technique. Surgical technique is obviously my wheelhouse. I will kind of elaborate on some subsets within there. So looking at breast cancer back then, so we're talking about early to mid 1900s. And you know, if we're going to talk about where we're going, we must have an idea of where we're coming from. So breast cancer was primarily detected by palpation only. We didn't have screening mammograms with the incredible imaging that Dr. Holtz talked about. The diagnosis was quite invasive with either incisional or excisional biopsies, so requiring likely a surgical intervention just for a diagnosis. And the surgical treatment was a Halsted radical mastectomy, which is pictured here. And so that is resection of the breast, the underlying pec major and minor muscles, as well as doing a complete axillary lymph node dissection. So there were times actually when patients went in for their excisional biopsy and then came out of surgery with a radical mastectomy. Treatment, when we're talking about adjuvant therapy, so radiation, the Cobalt-60 machine was used probably in the mid 1900s, and that was before we had any linear accelerators. And then endocrine therapy was quite invasive as well. So it was very much so effective with major ablative therapies, but did have some significant morbidity for patients. And then in chemotherapy, we had very few drugs available, very few drugs to even choose from, nothing that we see today. So looking at kind of the span of where we were and where we are now, you can see that in every single discipline of breast cancer management, we have progressed significantly. And this slide isn't meant to overwhelm with everything, but it's more to show you how far we've come. But it leads us to ask, have all of these new technologies actually made a difference in the outcomes of our patients? And the answer is yes, yes, it have. So this data shows the 5-year survival rates for breast cancer based on stage, whether it's localized, regional, or distant, comparing 1973 to 2019. And you can see a significant improvement across all stages, including distant, so stage 4 disease, we do see significantly improved survival rates. And then this graph shows our trends in female breast cancer death rates by race and ethnicity from 1973 to 2022. And across all races and ethnicities, you can see a decrease in breast cancer mortality. And so it may lead to us wondering, well, what led to this decrease in mortality? Was it our breast cancer screening? Was it some of our advances in treatment? And a recent modeling study estimated that about half of it is related to treatment improvement for stage 1 through 3 disease. Another third is improvement in our treatment of metastatic breast cancer. And then a quarter of it, about 25%, is associated with earlier detection through screening. However, when we look at the incidence of breast cancer over time, you see that there has been a continuous increase in the incidence. And then actually in 2020, breast cancer incidence surpassed lung cancer as the most common type of cancer worldwide, with the highest incidence and the second highest mortality. And this is the trends in breast cancer incidence among women, and this is based off of ethnicity and race, among women who are 20 to 49 on the left, and then 50 years and older on the right. And you can see steadily across all groups, there is an increase, specifically in our younger patients as well. So with the continuous development of new drugs and everything, we still know that there's room to go in treating breast cancer. And thus early breast cancer detection is key. So that leads me into breast imaging. I know we heard a wonderful presentation from Dr. Holtz about how we're improving our screening. And I'm going to kind of take a next step of what are some additional technologies we're using in our breast cancer screening. And I would be remiss to not mention artificial intelligence is, yes, infiltrating in this space as well. I will say, as a little disclosure, I am not a techie, nor do I have any kind of substantial foundation in AI or the tech industry, but I figured we could go through a couple of these definitions together. So artificial intelligence, it's the ability of a computer to learn algorithms, to reason and perform tasks including reading, writing, interacting, problem solving, and decision making. Machine learning is a subfield of AI, and it extracts features from training data set and builds analytical mathematical models for prediction and analysis of unknown data. So basically, taking what we know to predict what will happen with the unknown. Deep learning is yet another subset of that does not rely on handcrafted features, but learns more like the human learning approach. In AI, it is a great technology to excel in its ability to recognize and learn from high throughput data and a lot of information, which makes it really applicable in all realms of cancer research and management. So how do we apply it in breast cancer imaging? Well, there's a lot of data in breast cancer imaging, whether it's from mammograms, breast ultrasound, breast MRI, CTs, PET CT, and then it can be brought into the algorithms of AI, the deep learning, and then can be applied clinically anywhere from breast cancer screening all the way through to follow-up, drug discovery, and even prognosis. So the major characteristics that distinguishes artificial intelligence from CAD, you may see CAD on some of your mammogram reports, which is the computer-aided detection, is that the determinant of what image features are indicative of a lesion being present is achieved by the algorithm itself during its training, not by input from a human programmer. So some potential advantages: it reduces time of interpretation, reduces variability across studies, and that's actually, some studies have shown that it's better than experienced radiologists, which I'll touch base on the next slides. And claims have been made that image recognition using AI for breast cancer screening is better than experienced radiologists and will deal with some of those programmatic limitations like fatigue, burnout, as well as some subjectivity in reading the screens. But there are some potential harms. So there's a concern of increased rates of overdiagnosis and overtreatment. So identifying these really early stage lesions that may actually ultimately never end up becoming a problem. And it can alter the balance thus of benefits and harms. And then also, because it does kind of pull from the deep learning and the convolutional neural networks, there's a question of how does it actually determine what is significant and what is not? And we don't quite understand that quite yet. So one of the studies published by the NCI evaluated AI's performance compared to 101 radiologists. And this was using the Transpera breast care AI system. So the system provides a range between 1 and 10, representing the level of suspicion of cancer. And it compared how the radiologist did versus the AI. And you can see that statistically, the AI program was non-inferior to the actual radiologist read. I will say though, the performance was always lower than that deemed of the breast radiologist. So it didn't quite reach what we see as our excellence in our human radiologists. Is still underperformed compared to that. I'm going to jump gears into talking a little bit about surgical technique. Like I said, I'm a breast surgical oncologist. So the overall theme for advances in surgical technique, I'd say, is more on the realm of de-escalation of axillary surgery. And we're all aware, or some of us may be familiar, that an initiative of the ABIM Foundation in conjunction with the Society of Surgical Oncology released some guidelines back in 2016 recommending how we can choose wisely within our management of breast cancer. And one of the recommendations is to not routinely use sentinel lymph node biopsy in clinically node negative, meaning there's no abnormal lymph node seen or felt on exam or imaging, in women over the age of 70 with early stage hormone receptor positive, HER2 negative invasive breast cancer. Basically, the studies have shown that it is safe to omit sentinel lymph node biopsy in this breast cancer population. So that was back in 2016, which is now almost surprisingly 10 years ago. And so we've been able to pull this data and kind of expand this to see, well, are there other age groups and patient populations that we can actually de-escalate axillary surgery and omit sentinel lymph node biopsy? So within the last year in JAMA Oncology, this study was published. It's called the SOUND Randomized Clinical Trial. And that stands for the sentinel lymph node biopsy versus no axillary surgery in patients with small breast cancer in negative results on ultrasonography of axillary lymph nodes. This was an intention to treat analysis, and it included women of any age that had small breast cancer. So, and this is invasive breast cancer, less than 2 centimeters, and then negative preoperative axillary ultrasounds, meaning that the ultrasound took a look at the lymph nodes, actually visualized axillary lymph nodes, and there was no abnormal lymphadenopathy. So these patients were divided between those who received sentinel lymph node biopsy and those that had no axillary surgery. And they primarily looked at, well, what was the distant disease-free survival? And then secondary endpoints were looking at recurrences, whether it was distant or within the axilla, their overall survival, disease-free survival, and then was there a change in treatment recommendations? So when we look at the data, and the sentinel lymph node biopsy group is the one in blue, and the no sentinel lymph node biopsy group is the one in yellow, orange, we can see across in distant disease-free survival, the disease-free survival, as well as the overall survival, there was no significant difference between the two groups. Also, so this does kind of raise the question, well, does it change what we recommend for treatment in terms of radiation or chemotherapy? And actually, adjuvant treatment was overall very similar between the two groups in terms of radiation and chemotherapy. So it does provide further data supporting that axillary sentinel lymph node surgery does not provide really significant therapeutic benefit. And in the no axillary surgery group, the cumulative incidence of lymph node recurrence, so cancer coming back in the lymph nodes, was very low. It was 0.4% at 5 years. However, this does emphasize, before we start kind of really bringing this into a change in our overall practice, the need for multidisciplinary discussion, because it is discussing with our medical oncology colleagues as well as our radiation oncologies, making sure they're on board with us omitting the sentinel lymph node biopsy and axillary surgery in patients that fit this criteria. There are a few more studies on the forefront that should be published in the upcoming years, though, that will give us a little even more data. So we're looking for that. Now, talking about axillary surgery, and one of the reasons why we actually are trying to de-escalate is that the axillary surgery is not without morbidity and or complications. And one of that is the feared complication of breast cancer-related lymphedema. In an axillary lymph node dissection, so removing all of the lymph nodes from under the arm, there's an average of about 25% risk of developing lymphedema of that limb. You can see in the picture, some associated risk factors are the number of lymph nodes removed, some patient factors, diabetes, obesity, cellulitis, which is any infection of the arm, which taxes the immune system of that limb, as well as if they received nodal irradiation or radiation directed to the lymph nodes under the arm. So one of the surgical techniques that has been developed is something called a lymphovenous anastomosis or lymphovenous bypass. And that can be coupled with axillary reverse mapping. This is a picture taken from one of our lymphovenous bypasses or anastomosis during my time at MD Anderson. And what happens is, so basically myself as the breast surgeon injects the arm with some blue dye that reverses the mapping of the lymphatics. And then when I go in to take out all of the lymph nodes from under the arm, I can identify those lymphatic channels and protect them and preserve them. So then the plastic surgery colleagues can come in and they actually connect those lymphatics to different axillary vein branches that are distal to a valve to facilitate the flow of the lymphatic. So it basically bypasses the disrupted flow of the lymphatic tissue. So this picture, you can see the blue there, those are two lymphatics that have been barreled together to connect into a vein. And you can see that blue dye is draining into a vein. You can see that nicely in terms of the lymphovenous anastomosis. So there are two big trials that looked at, or kind of initial trials that looked at this technique and to see how does it improve, how much does it improve the risk of developing lymphedema. So LYMPHA is the lymphatic microsurgical preventing healing approach. In this protocol, the initial study looked at 46 women who underwent an axillary lymph node dissection. And they were separated into two groups, those that received the lymphatic bypass and those who did not. And at 18 months follow-up, you can see a significant decrease. Studies have shown anywhere from 88 to 90% decrease in the risk of developing lymphedema. And so one of the critiques of this is that it does require quite a bit of resources to do. You need coordination of time between the plastic surgeon as well as the breast surgeon. The plastic surgeon uses a microscope to identify these lymphatics and hook them up microscopically. And so the time and the resources are pretty significant. It makes it so it's not as applicable across the general communities across the nation. So Dr. Osman developed the S-Lympha protocol, which is a simplified version of this, basically where the breast surgeon themselves can take a very small suture and suture the lymphatic to the vein. And they looked at 194 women that underwent this, compared those that had the bypass, the S-Lympha bypass, and those without. And at 47 months, there was still a significant decrease in the risk of developing lymphedema in patients that had the axillary lymph node dissection. It went from 32% to around 15%, so a 50% decrease. Not as significant of a decrease as we saw in those using the microsurgical approach, but still, this is an approach that can be widely applicable to the general communities. So those are some basic kind of advances. I tried to be brief, I think, in my time, but I want to say thank you on behalf of myself, my incredible partners, Susan Lee Char, Joanna Ekmelang, as well as our advanced practice clinicians. We really appreciate Lily and the Community Health Resource Center and Dr. Peled for allowing us to participate in this wonderful webinar. So I think I'm the final one.
You are. Thank you so much. I love that. And those are some of my favorite advances as well. So thank you so much for talking about that. So we still have a little bit of time. So I'd love to get through. I've been trying to answer some questions live, but I think some of these will be really great to talk about as a group as well. So let's go, Daisy. Let's start from the top. This one I think is for you, which is what research is being done for BRCA mutations in terms of gene editing or therapy? Do we have any kind of exciting new advances in that?
So it's a great question. Definitely gene editing is a exciting part of the genetics field. For hereditary cancer syndromes, I'm not aware that there's any gene editing going on currently, but definitely something to look forward to for the future.
Love it. Thank you. All right, Elena, I'm going to send this one your way, which is there a true, I think people really want to know, is there a causal relationship in terms of breast cancer and alcohol? And I know that's a little bit of a nuanced topic, but would love any insight you can give anyone on that, please.
Yeah, there's definitely not a cause and relationship. So not every woman that drinks will develop breast cancer, even if, let's say, would not be moderate drinking. Definitely there is a correlation between estrogen positive breast cancer and alcohol intake. It's been shown to be at more kind of quantity sensitive. So the more you drink, the higher the risk would be. And, you know, for moderate drinking, actually the way it kind of developed, it's that women that drink every day a serving still seem to have a bit of a higher risk of breast cancer estrogen positive than women, let's say, they're not drinking at all or drinking maybe a couple of drinks a week. So usually the percentage, I think it's like somewhere between 11-13% higher risk when you drink daily 1 drink a day, which is considered moderation. the percentage actually increases with 2 drinks a day every day. So my approach when I talk with women and they ask me about alcohol is to say that if you drink daily, maybe consider to drink less often. When women drink, 2, 3, 4 drinks a week, I usually don't say to change much, right? So it's not about stopping drinking alcohol. It's not a cause and effect relationship, but decreasing the amount, especially if you feel like you're drinking on a daily basis.
I love that. And thank you for saying that. And I know you addressed this in your talk as well, but I think a lot of us see, totally understandable, there's a lot of guilt when people are diagnosed with breast cancer about like, what did they do to get it? And drinking is one, I hear a lot. And I think that allowing people to know that it wasn't causal, they didn't cause it. Breast cancer is multifactorial, but also that if you still want to have a couple drinks a week and that's part of your life and that's important, even after breast cancer treatment, I think it's really important for people to know that's probably not going to increase your risk at all and certainly not significant. All right, Jamie, can I give you this one, which is, I think this comes up a lot. This is specifically about deep flap breast reconstruction, what screenings are recommended. But I think really what they're kind of asking in my mind is if you've had a mastectomy, what do we typically recommend in that setting for in terms of imaging screening?
Sure, yeah. So in patients who have had mastectomy with flap reconstruction, the evidence on whether to continue with screening mammograms is mixed. Some studies have shown benefit to continued screening, while others have shown that clinical follow-up, meaning breast exams from a clinician experienced in performing them, was good enough, and screening mammograms did not really add anything on top of that. So the American College of Radiology says screening mammograms in these patients may be appropriate, sort of their more moderate recommendation. They use the wording usually appropriate for something that they're more strongly recommending. So it's sort of a complicated question and something that's unfortunately not very easy to answer. And then in patients who have had mastectomy with no reconstruction or mastectomy with breast implant reconstruction, the American College of Radiology is a little bit more definitive on their recommendations, in that they say that screening mammograms are usually not appropriate in these patients.
Super helpful. And I think, yeah, that's a big thing that comes up. We know no mastectomy is going to ever be perfect. Unfortunately, it doesn't reduce your risk of getting cancer to zero, although it dramatically reduces it. So, we like certainly as breast surgeons to try to see our patients back once a year into our clinics. I assume, Dr. Carlson, you do something similar in yours, basically. So everyone's getting a good breast exam once a year. And we also teach people how to do breast, self-exams at home. And so I recommend continuing, monthly self-exams, and we check your lymph nodes, check by your collarbone. And, again, fortunately, the risk is really low, but it's nice to still continue to be actively involved in that. Okay. And then Dr. Carlson, I'm sending this one to you, which is, I love this question because it's kind of related to your talk about doing less, which is, what are some of the ways we decide whether or not radiation is necessary after breast surgery? And how can we make decisions about that?
That is a really great question. So a lot of it depends on final pathology. So after surgery. So unfortunately, up front, we can get an idea based on tumor size and characteristics and age of patient of whether or not it's safe to omit radiation even after breast conserving surgery. But we don't know the final recommendation until we get the final pathology. So after surgery, we can really determine, the final tumor size, because sometimes it can change a little bit from the time that, of imaging to what you see actually on pathology. But I think there's a lot of factors, including patient age, the biology of their cancer, what surgery they had, and whether or not lymph nodes are involved. And I think it brings up a really great question to meet with the radiation oncologists to determine if you're a candidate for omission of radiation. Because just as we have kind of expanded omission of axillary surgery or de-escalation of axillary surgery into the breast surgery realm, we are actually starting to de-escalate some of our radiation therapy recommendations in the radiation oncology realm. So great question. And if you're even kind of considering radiation or not with your surgical options, I would recommend meeting with a radiation oncologist upfront before surgery to really talk about some of those options.
Perfect. Thank you. All right. let's see, what was I just looking at? Oh, Dr. Holtz, I'm going to send this back to you because I think this is kind of part of when we're doing screening at the breast center and they were asking about kind of factors associated with estrogen. Do you want to talk just briefly about like what are some of the factors that we take into account when we're kind of making a risk model in terms of things that are related to exposure to estrogen or kind of reproductive factors like we talk about?
Sure, yeah. So things like the age that you started your menstrual period, the age that you started menopause, whether or not you use hormone replacement therapy, whether or not you've been pregnant, whether or not you were breastfeeding, all of these things kind of influence how much exposure to estrogen you've had over your lifetime. And so these are questions that are asked and are screening questionnaires and during risk assessment for breast cancer, lifetime risk of breast cancer.
Great, thank you. I'm going to try to get in 2 more questions. So Elena, I'm going to send this to you, which is asking about for people who've gone through mastectomy, presumably, let's say for breast cancer treatment, are there any recommendations around dairy and eggs? Is there any thought that either of those increase risk?
Yeah, dairy, I hear more concerns around increased risk of breast cancer, but the reality is that the evidence is kind of mixed and is not very strong at this point. There's studies that had a correlation with especially high-fat dairy and increased risk of breast cancer. I think was mainly in premenopausal women, but then other studies, and we're talking about maybe 20 other studies that really did not show that, or actually some studies show that dairy can be protective. So actually the research is a bit all over the place. So at this current time, I usually tell women to consume dairy, 2 servings a day. I think it's considered in moderation and can be a good source of calcium in your diet, especially if you're approaching menopause or you're going to start aromatase inhibitors and all those treatments that, can increase the risk of osteoporosis. And try to choose the lower, low-fat, non-fat options. So then you kind of minimize the saturated fat that comes with dairy products. You could get benefit from protein, the calcium, the other good nutrients. And this would be the recommendation that I give right now, since we don't really have any other data. I also like to emphasize like yogurts or kefir, because they're fermented foods and can create some additional benefits through the live cultures. And so dairy, it's fine. And the eggs, the same. Eggs actually have even less controversially. Eggs are considered lean protein, and an egg a day kind of on a regular basis is considered as part of a healthy diet. So we don't really have much more information on breast cancer risk with those foods.
Thank you so much. And then I'd like to just end with this last question, because I think this is it comes up a lot. So Kjirsten, the question that I get a lot, and this is one in here too, is does the risk of lymphedema, like, does it continue over time? Does it get worse with time? And kind of how long do we monitor people for thinking about their developing lymphedema?
Sure. So we do know that the peak incidence of developing lymphedema is within the first 2 years after surgery. So that's kind of the hotspot time to really monitor. However, I will say I have seen patients that are 15 years out come back with lymphedema. So those cases are very rare. And like I said, most commonly it's within the first 2 years after surgery, but it is something to always kind of monitor and keep an eye out for, that if you start noticing, any swelling, like your watches aren't fitting right, jewelry starting to feel really snug, it's very nice, just come back and get evaluated by one of your clinicians, and they can get you kind of evaluated by an occupational therapist that does certified lymphedema therapy, and kind of just take a look at them. So, but yeah, that's a very good question.
Thank you so much. So I wanted to thank, first off, Lily, thank you again so much for hosting all of us, and also to all of our panelists. I have to say, this is one of my favorite ones that we've ever done. You all gave really fantastic talks. I think were incredibly helpful. And then to everyone who joined tonight, thank you so much. There'll be a recording as well. I know we didn't get to all the questions, but all of us are happy to answer. And so feel free to send anything else through Lily, and we can answer in the future. So thank you again so much, everyone, and hope you have good evenings.
Thanks, everyone. Take care.